Hi, good evening. I'm Lonnie Stonich, the Executive Director of FAN. We're a nonprofit that presents programming exploring human development across the lifespan. I'm honored to welcome you to tonight's conversation between Professors Lauren Freeman, Heather Stewart, and Yolonda Wilson. Thanks for joining us. FAN's YouTube channel has an archive of over 350 videos of past events, so be sure to subscribe to the channel to get updates when new recordings are posted. Tonight's recording will be posted this week. And now for some introductions. Lauren Freeman is a professor of philosophy at the University of Louisville and director of the MA program in applied philosophy. She conducts impact-driven interdisciplinary research that aims to understand how members of marginalized groups are oppressed in both obvious and subtle ways within the context of science, medicine, health, and healthcare. Freeman is known for pushing bioethical and medical research to include patient groups who have traditionally been excluded from discussions, specifically patients who are marginalized based on sex, gender, race, body size, and disability. Her research has been featured in Nature and chosen as the feature article in prestigious health sciences, philosophy, and policy journals. Heather Stewart is assistant professor of philosophy at Oklahoma State University. Her research and teaching take an intersectional feminist approach to analyses of medicine, healthcare, digital technologies, and artificial intelligence, with a particular focus on how power, oppression, and privilege shape individual and collective engagement with these institutions and technologies. Her work also aims to illuminate strategies for mitigating the myriad harms and injustices that occur for marginalized people and communities in these contexts. Yolonda Wilson is an associate professor of philosophy in the Department of Healthcare Ethics at St. Louis University. She has also worked as a visiting scholar in the Department of Bioethics at the National Institutes of Health in Bethesda, Maryland. She conducts research in bioethics, social and political philosophy, race theory, and feminist philosophy. And now let's welcome Professors Freeman, Stewart, and Wilson to FAN.
Thank you so much for having us. I'm just really excited about the conversation that we are going to have. I know that it's going to be great. And so thank you, Lonnie, for the introductions, and Anne-Marie for all of your behind the scenes producer work.
And thanks to everybody for coming. We're so honored that there's apparently like 250 people here. So welcome.
Oh, that's really exciting. Yeah. So I just want to start. I want to actually take a point of moderator privilege here. And first of all, just thank you for the book and the conversation. And you open up with one of the early examples in the book is about a 19-year-old patient who had an ovarian cyst that was rupturing, and the emergency room provider was very preoccupied with the possibility that her symptoms were connected to sexual behavior or pregnancy that she just didn't want to admit to. And I just wanted to let you all know how much that resonated with me. I thought, have they seen my journals or something? Because when I was not, like literally the same age, 19, the same kind of thing happened to me. And so I know that you all have these research interests, but I'm also interested in what prompted you to write the book? I mean, I'm sure that there are a lot of people in the audience who can tell similar stories about some of the vignettes that you presented.
Yeah, thank you so much, Yolanda, for joining us in this conversation and for sharing that personal experience. I feel like every time we talk about this book, we have people say like something to that effect, right? Like, are you reading my journals? Because I've had experiences very similar to that. In terms of the origins of this book, they actually go back almost a decade, which feels very bizarre to say. But about 10 years ago now, I was a student actually in Lauren's graduate seminar on the foundations of bioethics. And in that seminar, we were reading what's taken to be a sort of seminal text in bioethics, Beecham and Childress's text, Foundations of Bioethics. And in reading and discussing that book, we began thinking through the way that traditional mainstream bioethics tends to use the concept of harm in a way that we found very sort of narrow and reductionist. In that text, they talk about harms that occur in medical contexts as being exclusively physical in nature. They say by harm, we mean physical injury, bodily harm, or death. And kind of just the kind of case you were just talking about. We thought, well, there's lots of ways that patients can be harmed that maybe aren't exclusively physical in nature, or even predominantly or primarily physical in nature. And when we conceive of harm in that narrow way, we obscure all of the various kinds of harms that patients can experience that aren't necessarily physical. So we took that as kind of an opportunity and an invitation to really start thinking about those non-physical harms. And that led us to start discussing the phenomenon of microaggressions that we're going to talk about together tonight.
I just wanted to make sure I didn't want to start talking, getting very excited if Lauren had something to add to the story. So what happened intervening 10 years? So have you been thinking about it this whole time? Has the project undergone multiple iterations? Is it like some of my projects where you put it down and come back to it? What's happened?
Yeah, I mean, so like, I really want to say that the book sort of started as a series of like marginalia between, professor and student. And we would sort of continue conversations that we had in class. And, Heather would write something brilliant and I would comment on it. And we would, meet in office hours. And, I don't know about how you write, but it rarely sort of takes a straight route. So it went through a number of iterations, and we, the project sort of started as like a deep engagement with these, seminal figures in bioethics. And then we sort of thought, you know what, that can sort of be the ladder that we throw away. Like, this book is engaged in, I think, central, discussions and debates in bioethics, but we sort of came across this idea of microaggressions, and it sort of allowed us to find a way of answering this question of like, how do we better understand harms, not just, the big and obvious ones that sort of come to mind immediately, but we were really interested in looking at patients who are members of marginalized groups and the often peculiar kinds of harms that for them are real, obvious, clear, and yet often don't really get reflected, or like what philosophers like to say, get uptake when they're spoken about. And so how is it that there is this type of harm that for the people who are experiencing it is so real and clear, and yet when they talk, when they try and tell their healthcare professional or family members or a spouse about it, they, get met with skepticism or gaslighting. And so when we discovered, like, 10 or 11 years ago, this concept of microaggressions, and nothing had been written about microaggressions in medicine, the term really grew out of discussions in clinical psychology. We thought, wow, like there is an answer to this question that was raised about these particular kinds of harms that really are not discussed in bioethics literature or medical literature. So it was, and then of course, 10 years later, it grew into this, but it was not a straight path, let's say that.
So you landed on microaggressions, and one thing that I found really interesting was how you traced the concept, the idea, and you actually point to the 1970s, right? Where there's this initial discussion, and then there's not a lot, and then it kind of blows up again. So anybody who's on social media in any kind of way, and I'm there entirely too much, sometimes to my detriment, but like the last 3 years, I would say there's definitely a lot of conversation about microaggressions. Some of it done well and some of it not, because social media is a mixed bag. But could you just take us back to the 1970s for a little bit and just talk about the micro and microaggressions?
Yeah, so it's
how you think that's evolved. Yeah, sorry.
It's a really interesting history. So in 1970, there was this Black Harvard psychologist named Chester Pierce, who was one of the only Black professors at Harvard. And he noticed that there were all sorts of, to anybody who would be observing the situation, seemingly subtle ways that he was treated very differently from all of his colleagues. And of course, when he brought this up with his colleagues, nobody knew what he was talking about because he was one of the only, if not the only, Black professor. And so he started talking about these kinds of what he called racial microaggressions. And there's a lot more to say, and we talk about this in the first chapter of the book. But what's really interesting is we looked at the numbers when we were writing the book. So I think between 1970 and 2007, there were 321, or like some low number of articles in all of those years. And in 2007, a Columbia psychologist, Daryl Sue, and a number of his co-authors sort of reinvigorated this concept. And they wrote this important article in 2007 about racial microaggressions. And it sort of just catapulted or resurrected the term in a way that was quite unforeseen, given that virtually nobody had been talking about it for the last 30 years. And I haven't done a Google search like in the last couple of months, but I think, Heather, the last time we did it when we were writing the introduction to the book in I think 2023, there were over 20,000 articles on microaggressions. And so I think that's saying a lot. There's a lot of ways. And of course, the term grew beyond just talking about racial microaggressions to talking about, microaggressions that all sorts of members of marginalized groups experience. And, Yolanda, as you sort of suggested, when any term that's introduced in a very technical academic setting gets, blown up on social media and in popular discourse, there's something really good and important about that. It's definitely describing a very real phenomenon, although some people would disagree with that. But it also gets misused, and it gets sometimes intentionally misused. So, what we're doing in the book is continuing on in this tradition that Chester Pierce and Daryl Sue and his co-authors started, but we are also importantly critically engaging, especially with Daryl Sue. We're obviously indebted to his really important work, but the first 3 chapters of the book are sort of a critique and development of his term, of the term microaggressions in ways that he, didn't really think about it.
Yeah, so on that thread, I'm actually interested in the distinction that you all make with your account from kind of focusing on microaggressions as acts and focusing on maybe the perpetrator or the perpetrator's intentionality versus the account that you propose, which is a focus on harm and those who are on the receiving end of microaggressions. Can you all just say a little bit about, what that distinction is, first of all, for our listeners?
Yeah, so without getting like overly into the sort of theoretical weeds here, in the book, we make this distinction between, as you said, Yolanda, a sort of act-based model or approach to understanding microaggressions and our novel sort of harm-based approach to understanding microaggressions. And in that sort of robust literature in psychology that Lauren was just kind of giving an overview of, the focus is really on the kinds of acts that microaggressors are committing, right? So maybe if you're familiar with microaggressions, you've heard concepts like micro insults, micro assaults, micro invalidations. Those kinds of ways of thinking about microaggressions and labeling microaggressions are focused on what someone is doing, right? Are they doing an insult or an assault or an invalidation on some kind of more minor micro scale? And our approach, on the other hand, kind of flips the script. So instead of focusing on the acts that a microaggressing agent are doing and whether they're doing them intentionally or not, we're more interested in what's experienced by the people on the receiving end. So that leads us to think about and categorize microaggressions as resulting in different kinds of harms. And we talk about some different categories of those. I'm not sure if we'll get into that or not. But we see this approach as really shifting kind of the center of attention in the discussion of microaggressions from those who might be perpetrating microaggressions, again, intentionally or not, to those who are on the receiving end, right, who are most often members of marginalized groups. That's really something novel that our account does, is really gets us to focus on those harms that are experienced. And one sort of benefit of that is, Yolanda, you mentioned that like this is a concept that sort of gets talked about in better and worse ways on social media, sometimes in ways that are incredibly dismissive, right? And we think shifting that perspective kind of helps us to focus on what people are experiencing that, even though it might be easy to dismiss from the perspective of the person who's committing it, can be really impactful for the person who's on the sort of constant, frequent, reoccurring receiving end.
Something else I would just add to that, and this might be like a disciplinary difference between psychologists and philosophers, and like no shade to any psychologists in the audience, we love you. But what we found when engaging with Sue's work is that he would give these like really robust accounts of what was going on when a microaggression was happening. But all of the different kinds of microaggressions that he develops would all just result in harm. And so as philosophers, of course, we're just like, wait, like, what do you mean by harm? What kind of harm? Is it like a moral harm? Is it a harm to one in one's capacity as a knower? Is it like a harm to one's identity? Like, what kind of harm? And so we were sort of searching for these more nuanced, fine-grained analytic distinctions that weren't there in the psychology. And so that sort of presented us with this opportunity as philosophers, the people who like to do that nitty-gritty, those analytic distinctions. And we were like, well, we really want to know, like, presumably if there are different types of microaggressions, presumably they result in different kinds of harm that are importantly different, right? Because if they're different microaggressions, they don't just all result in this sort of bubble of harm. So that's why in starting with what we call this harm-based account, we're guided by the consequences of the microaggressions, which we think sort of helps give a better analytic account of like why these are so problematic and wrong and morally harmful and harmful in other ways. And it's understandable, if a clinical psychologist is setting out an account, they aren't asking the same types of questions that philosophers ask. And so I think this is really a necessity for real interdisciplinary work on all of these kinds of concepts, because different disciplines just ask different questions and are engaged, from different perspectives.
Now, what would you say to a kind of dyed-in-the-wool political philosopher like myself, who's like, no, I want to know about these acts because I want to know where to lay the responsibility and the blameworthiness. Like that's right. Even if I don't care about the intentionality, like I want to know who we can hold accountable here. Like that's the old Hobbesian in me, right? Who's very preoccupied with things like accountability. Is there room in your account for thinking about that, or is that just, not the aim of what you're doing? You're just doing something, you're just doing a different project.
Yeah, I think there's certainly room for an account of responsibility that doesn't depend on intentionality, right? So we can say, insofar as these actions are causing serious harm for their recipients, right, then there's some responsibility to try to rectify that harm or to try to prevent that harm at the outset, even if there's not necessarily blameworthiness. So without boring the non-philosophers about that distinction, right? But yeah, so I think it's perfectly consistent with our account to think that because we think these are actions that do result in harm, then there is a moral responsibility to try to offset that harm or prevent that harm and the negative effects that it brings about.
Now, one category, you talked about the categories that you give us as readers to kind of wrap our arms around microaggressions. And the first category, I don't remember if it's the first that you present in the book, but epistemic microaggressions. First of all, can you tell us what epistemic means?
Yeah.
and how there can be microaggressions in a kind of epistemic kind of case?
Yeah. So again, you don't have to be a philosopher to understand any of this. We will omit all of the jargon. So epistemic just refers to somebody in their capacity as a knower. So if anybody in the audience has ever tried to express something, let's say in a medical context, about your body, about what's going on, and you just sort of get a blank stare, or, the healthcare professional, rolls their eyes or just expresses some kind of skepticism, and you say, no, this is really happening. Like, this is what I know is going on in my body. And, either in subtle or less subtle ways, your claim to knowledge, your claim to know what is going on in your body is not believed or ignored or just sort of undermined. That is what we're calling an epistemic microaggression. So it's a microaggression that somebody experiences in their capacity as a knower. And in any context, that can be very harmful, because we are beings who know things and express things. And when what we know to be true, especially about our body, when oftentimes we are the best judge of that, isn't taken seriously or isn't believed or is downplayed or ignored or not recognized, that results in what we call epistemic harm. Now, I can talk about sort of one of the cases in the book, because I think it's really common, and there's lots of cases, but one that I'll choose because I think the audience here probably knows of this person. So in the book, we use all real cases, and they're just cases from the newspaper or podcasts, or, for example, what I'm going to be talking about now, the case of Tressie McMillan Cottom, who is a Black anthropologist or sociologist, who wrote a wonderful, harrowing book called Thick and Other Stories. And one of the chapters, and the title of the chapter is called Dying to be Competent. And it profiles her really harrowing experience of miscarrying. And so it's a pretty long story, but to just summarize it, basically she was 4 months pregnant. She knew something was the matter. She was bleeding, and over and again, she went to a doctor. She's a self-described fat Black woman. And he said, oh, this is totally normal for somebody like you. You probably just ate something that wasn't good for you, ate food, that you eat. And she was sent home, called the nurses. The nurses kept saying, oh, well, the pain is, here, not there. So clearly nothing's the matter. It's totally normal, totally normal. And she ended up miscarrying. And the nurses, over and again, were just sort of saying, well, you should have said something. Then we would have known what was the matter with you. So this series of, at the time, micro and then also very macro aggressions. And so McMillan Cottom sort of unpacks what's going on with her. She doesn't use the language of epistemic microaggressions, but that is one of the many types of microaggressions, in addition to the macroaggressions, that are happening to her. Namely, she knew from a first-person perspective that something was very wrong. She was expressing this to her healthcare professionals, and over and again, they didn't take her claims seriously. Was it because she was a woman? Was it because she was a Black woman? Was it because she was a fat Black woman? But what's really interesting in the case, and we can say more about this, and we can go into this in the after hours if people like, because there's lots more to say. But one of the really interesting things that the way that she describes this case is that she knew that were going to be credibility issues given her social identity. And so she writes explicitly that, she chose a doctor who primarily treats wealthy white women. And so she, chose that doctor sort of signaling, hey, I'm in that category, even though she wasn't. She intentionally wore a wedding ring. She used all of these social cues to sort of try and offset the identity stereotypes that she knew she would be experiencing. And yet she still, I don't want to use this, I don't want to say she failed, because, she did everything right, and yet it didn't work out, even though she was anticipating these things. And so we analyze this in terms of the microaggressions that happen that are really subtle, yet that result in quite macro and in this case, tragic harm. But we do want to draw a distinction. So the outcomes are not micro, but a lot of the things leading up to the outcomes that could have been done very differently, we analyze in terms of microaggressions. So that's the epistemic, and there's lots more examples that we can talk about later.
Just to drive something home, because Yolanda asked, like, what makes this like epistemic in nature? And in her book, Macmillan Cottom actually, like, I think the chapter is called "Dying to be Competent" or something like that. But she talks about this problem of Black women being sort of automatically perceived as incompetent, as non-knowers. Even in her case, when, right, she's a professor, she's a public intellectual, she was a recipient of a MacArthur Genius Grant, right? She has all of these ways of signaling that she has credibility, a certain kind of knowledge that we might think would get uptake in this context, and yet still, right, the pervasiveness of those stereotypes and biases and assumptions that Black women aren't knowers, right, aren't credible givers of knowledge, still impacted her in this case, right? And that's kind of the epistemic component there.
So what's the connection? Both of you have talked about stereotype, or it's come into your description of epistemic microaggression and Cottom's case in particular. What is the connection between either stereotype and microaggression generally, or stereotype and this particular kind of epistemic microaggression? Can you just give us a bit about that, because it's coming out a bit?
Yeah.
Yeah.
Go ahead.
Sorry. We knew we'd do that at least once. Yeah. Part of what microaggressions are, right, are there these manifestations of these widely held social stereotypes and biases, right? If we can think about some that probably everyone's familiar with, whether or not they want to say or admit that they hold them on a personal level, right? But the stereotype of the angry Black woman, right? Or the stereotype of the hysterical woman or something like that, right? And these kind of pervasive stereotypes are at the core of what leads to microaggressions in these contexts. So if you think about some of the things happening in the case that Lauren just described, right? Tressie Macmillan Cottom was told, maybe you just ate something that was bad for you, right? Well, what kind of stereotypes is that playing on about Black people, the food they might eat? Again, Tressie Macmillan Cottom self-described as a fat Black woman. So, right, what angle does her being a self-described fat woman play into this assumption of like, oh, you just eat bad, unhealthy food of the type that fat Black women eat, right? So those kinds of stereotypes that, again, we're all probably unfortunately familiar with, really are at the root of what causes microaggressions to occur. Lauren, I cut you off a moment ago.
Yeah, no. The only thing I would add is that, microaggressions are most often unintentional. So we have to think of like what kinds of things in the background are driving us to make certain assumptions and say certain things, even when we don't intend to cause harm. And so stereotypes are one of the mechanisms that drive a lot of the cognitive shortcuts that we take, and often are the drivers of microaggressions. I mean, if there's psychologists in the audience, they might have a more nuanced answer, but I think there is a deep connection between stereotypes and microaggressions.
Yeah. So, Heather, in your explication of that connection, you talked about the stereotype of the angry Black woman, and you also describe in the book, I guess, another kind of microaggression, the emotional microaggression. And so I thought that would be a nice segue into telling us a bit about what that is, how recognizing or making judgments about emotions or emotional state or emotional capacity turn into microaggressions, or how they play on microaggressions.
Yeah, so Lauren just described one category of microaggressions that we identify and talk about, which are ones that are epistemic in nature. Another that we talk about are what we call emotional microaggressions, which result in certain kinds of harms to their recipients as people that emote, right? As people that have emotional experiences that are significant to them, that they want to be taken seriously, and so on. And to get back to the conversation we were just having about stereotypes and the role that they play here, we understand emotional microaggressions as being sort of rooted in these stereotypes about what normal or appropriate emotional responses are, which we might think are rooted in a certain kind of presentation, maybe one that's kind of white and middle class and things like that, what proper emotional responses may be, and then how those kind of come apart from stereotypical emotional reactions of people of marginalized groups, right? So I mentioned before the stereotype of the quote unquote angry or aggressive Black person, perhaps particularly Black women, or you might think about the stereotype of the overdramatic or overly emotional woman, perhaps especially white women, dare we say the stereotype of the hysterical woman, right? So all of these kinds of tropes and stereotypes come into how we perceive the emotional responses of other people. And in some of the cases we analyze, people are trying to express some kind of emotional response, either to their condition, to their symptoms, to the degree of pain that they're in, and they're being told that their emotional responses are inappropriate or misplaced or overblown or otherwise not appropriate to the circumstances or to what they're experiencing. So this connects with concepts like tone policing, maybe if people are familiar with that kind of concept. But this idea that there's an appropriate emotional reaction and the one that you're having or demonstrating is not it, right? And that connects to gender and race in a number of ways. So we talk about a number of cases of this in the book. One case that we talk about, it's about a patient named Rachel. Her husband, Joe Fassler, writes about the case in a really harrowing piece in The Atlantic. And in that piece, you have a woman, Rachel, who's describing being in just the worst, most intense pain of her life. She's kind of expressing that in a variety of ways, having emotional responses to it. She's crying, all of these things. And she's repeatedly told, just calm down, honey, just a little pain. Lots of patients experience this. She's told explicitly not to cry, right? So these kinds of reactions to her emotional experience are the kinds of things that we're talking about. And just like in the case that Lauren just described of Tressie McMillan Cottom, there are these emotional microaggressions that are occurring, being told not to overreact, being told not to cry, and they have some connection to the sort of macro and tragic things that end up happening. In this case, she's initially misdiagnosed as having kidney stones, when in fact she had ovarian torsion. And in this kind of case, we think those early emotional dismissals are having some kind of effect on that sort of tragic result. They're also affecting her as an emotional being. So in that piece, she describes this kind of case as the trauma of not being seen. So it was really significant to her that her emotions weren't seen, given uptake, or respected in that kind of case.
And what's really important in these kinds of cases, and this is something that's often, we think, sort of intentionally misunderstood by critics, right? So there's a whole group of critics that think that microaggressions aren't real. If they are real, they're really not that big a deal. People just need to grow a thicker skin, grow a spine, and just get over it. And so this is just something that's really fascinating about the very concept of microaggressions, because there is a real sense from the perspective of the person committing them that they are nothing. Oftentimes, people who commit microaggressions don't even know that they've committed them. So there is a real sense in which, from that perspective, they are micro. And yet, from the perspective of the one on the receiving end, not only are they harmful in that moment, and we're interested in microaggressions that happen in medical contexts where the person on the receiving end is not just a member of a marginalized group, but also a patient who is by definition vulnerable, in pain, sick often. But they're not just harmful in the moment, although they are harmful in the moment, but they also have all sorts of enduring and long-term consequences. So when Heather mentioned Rachel's, very harrowing description of this trauma of not being seen, that's something that stayed with her for months after. And in the article, Joe Fassler talks about how Rachel would wake up in the middle of the night and having panic attacks of not being seen, not being believed. And so I think that one case is a really important and emblematic way of showing that microaggressions, despite the the part of the word that says micro, are not micro. So like they both are and they aren't micro. And Heather and I have spent so much of the last 10 years sort of debating in Q&As at talks, people are like, well, if they're so macro, why not just call them aggressions? But that doesn't quite work because most of the time they are not intentional. They're committed by people who are trying to help, right? Healthcare professionals are there to help people. They're not doing these things most often intentionally. And so the reason we keep coming back to the term and we're not willing to give it up yet is because there is something that at the same time is both micro and very much not micro. And so it's this peculiar concept that we're not willing to give up, even though there are problems. And one of the problems with the very term is that people say, oh, if they're so micro, why are we talking about them? Like, big deal, get over it. But we don't really want to go with that.
Well, I certainly think in the healthcare context that the stakes are just different. So, right, a kind of, as Heather's recounting the story, don't cry, honey, or stop crying. Like, oh, lots of people have pain in the emergency department. That's just part of, like, that's why you're here. Of course, you're not feeling comfortable. It's not that big a deal. And yet, from the Atlantic article and, of course, from your retelling, Rachel's case escalated, right? So what was just a kind of don't cry, honey, borderline pat on the head and very dismissive and actually an emotional microaggression, to use your term, turned into catastrophic. Has very specific meaning in a healthcare context, so I won't say catastrophic, but it turned out to be incredibly significant, right? She lost an ovary. And I believe, if I'm not mistaken, that the surgeon told her in another couple of hours she could have lost her life. And so, had there been that emotional uptake, right, it wouldn't just be preventing this emotional harm, but given the healthcare context, the stakes are just different. And so I'm wondering kind of how you think about that. I mean, like that aspect of it is really serious and significant in a way that I don't want to say other contexts are less significant, but there's a kind of immediacy, at least in some instances, that are literally life and death in the kind of immediate way that you can see and feel and almost quantify. I mean, to be told, oh, 3 more hours and you wouldn't be here with us anymore. That's got to be incredibly unsettling. And, especially when you tried and you tried and you tried. Oh, was that just me pontificating?
No, Heather, did you want to respond to that?
And then there was there.
Yeah, no, absolutely. I mean, yeah, I think to a point Lauren made earlier, right? In these kinds of in these cases, like some pushback that we often get is like, well, how can you, like, given what Yolanda just said, right? In the case of Rachel, she lost an ovary, she was at risk for sepsis and even death, right? Like, what is micro about this? And part of what we want to bring out is that in these cases, had those kinds of things not occurred, right? In the case of Tracy McMillan Cottom that Lauren described, right? Had her knowledge of her sort of body been taken seriously at the outset, in Rachel's case, had she been given that sort of appropriate emotional uptake, maybe we don't escalate to that kind of situation where there is ultimately, in the end, in both cases, a loss, right? In Cottom's case, a loss of her child, and in Rachel's case, a loss of an ovary, right? Risk of other kinds of physical injury and death in that case, right? Maybe we don't get there, right? So maybe some of these micro things at the beginning that, again, seem small from the perspective of the person who's committing them, who is probably well-intentioned in Rachel's case when the nurses and folks are telling her, like, calm down, honey, don't cry, it's just a little pain. Like, that's probably being offered with the intention of being comforting and right, being supportive and all of those things. And yet, because there's a failure to take seriously the depth of her sort of emotional response there, we end up in this escalation, right? In this place that perhaps could have been avoided.
One thing that I think about as a feminist and as a feminist bioethicist is that, particularly when it comes to thinking about women and emotion, and as a Black woman whose emotion management and emotion presentation has has a different kind of salience for me. It seems as though, not just with emotion, but with a lot of things dealing specifically with women, but since we're talking about emotion, there doesn't seem to be a right response, right? So if Rachel goes in and cries hysterically, and I don't know if she was crying hysterically or not, but just the mere fact of crying, right? It becomes a thing to be managed and tamped down and dismissed. But if Rachel goes in and she's completely stoic, then that becomes kind of evidence that there's nothing quite wrong, and maybe you can go see about someone else or deal with someone else. And so there just seems to be this bind for women. And you talk about it in the book, but I'm just curious, right? I mean, a lot of ink has been spilled, how to get, if you're a woman, how to get taken seriously in business, how to not be, wear shoulder pads, don't wear shoulder pads, go play golf, don't play golf, make your office look like a living room, don't make your office look like a living room, and we seem to get the same kind of thing in healthcare spaces, right? Advocate for yourself, but don't advocate too much. Cry just the perfect amount, but not enough that people think you're, making stuff up. Like, how do you?
Yeah, I mean,
how do you deal? How do you think about it?
It's a really good question, and you're absolutely right. And in the book, we do talk about this double bind, and we talk about cases where, especially, women who know the data, who know the stories, and they know that if they go in hysterical because they are legitimately in a 10 out of 10 pain, they'll be written off as hysterical women. Yet, if, as you said, if they go in stoic because they want to offset the hysteria, stereotypes and the mistreatment they'll receive, then the response is, well, if you were in a 10 out of 10 pain, you would be emoting a little bit more. And some physicians actually coach their patients, in exactly the way that you say, like you have to just exhibit the precise right, like the Aristotelian mean. You have to be, emotional, but not too emotional, stoic, but not too stoic, like just the right amount. And we sort of really recoil with that kind of advice and putting the onus on patients to sort of be the best advocate, be the kind of perfect patient. And, it's really frustrating and it's really difficult because, of course, we want to advocate for patients, but we don't want to say, patients, you need to take responsibility for your health and you need to present as the ideal patient so that you'll get taken seriously. So I think that there's a sense in which on the individual level, there isn't a great answer to that question. The way that Heather and I like to think about it, though, is really to sort of push the burden. And I don't think it's a burden. I think this is like a professional responsibility into the structural and pedagogical level. Like, healthcare professionals and medical students need to understand sort of these pressures on patients. And, in the way that we like to think about this is, in a physician-patient relationship, that relationship is sort of infused with power differentials. And those power differentials need not necessarily be problematic, right? There is a sense in which when I go to a doctor, like the doctor is the expert, I am the patient, they have more social power and professional power and epistemic power in certain ways over me. And that power differential can be used well or not. And the way that that kind of power differential can be used well is if, physicians and sort of not just individual physicians, because this is not like an issue of like a few bad apples, right? This is a systemic problem, but there have to be better ways of allowing knowledge to be transmitted, and better listening, having doctors spend more time. So that's sort of on the individual level, but there is also the problem of stereotypes, right? And we're philosophers. So how do you get rid of stereotypes? How do you change stereotypes? Like, I do not know. But I do know that, the listening picture and understanding, when stereotypes might be operating in certain ways healthcare professionals can sort of ask themselves questions, right? Like in the Tressie McMillan Cottom example, would the physician have said to a white woman who was in the same situation, you probably just ate something that was bad for you, right? So if not, why not? And then why did he say it to the Black woman? The issues of pain, and there are so many stereotypes that are operating in terms of these emotional microaggressions, but we're really reluctant to put the burden and the onus on patients to sort of, you need to be the perfect patient if you want to be taken seriously, if you want to get the best treatment. And we want to push back and sort of look at the system and look at the structure and how can we create a better context for better health outcomes for all patients.
And that's acknowledging at the same time that it can be at the individual patient level wise and strategic to do those kind of things, right? To try to strike that balance or find that mean that Lauren mentioned, right? But it's also to point out that even when that's happening, so like in the case that Lauren described of Tressie McMillan Cottom, she thought she was doing everything right, right? She knew that she would be up against these stereotypes as a self-described fat Black woman. She tried to put herself in a context where she was more likely to be listened to, taken seriously. She thought she chose her healthcare providers wisely, all of these kinds of things. So on some level, she is trying to advocate for herself or be empowered as a patient and all of these things that we're kind of advised to do in all of the sort of popular pieces that we see on social media, right? And so she's doing all of those things, and yet, right, she's still against these kind of structural and systemic biases and stereotypes that are operating in the background.
Yeah, I'll just say one other thing that came to mind, and I sort of had meant to bring up this example, but there was this wonderful book that Heather and I love that really influenced and gave us a lot of cases that we used for the book from 2018 by Maya Dusenberry, who's a wonderful science journalist. The book is called Doing Harm. And she talks about this patient, and I just remember this because the patient's name was Lauren, but spelled Loren. And Lauren talked about how she was the daughter of a healthcare professional and she was clearly having she was experiencing appendicitis. And because her mom was a healthcare professional, she explicitly went in trying to be that Aristotelian mean, right? She was trying to be stoic, but not too stoic, emotional, but not too emotional. And she was still sent home, right? So it just sort of shows that, like, as you said, Yolanda, like there's this double bind where you have two options, both of which are not great, and both of which often result in poor care. So the question for us and for healthcare professionals is, how do we change those structures? And we'd be really excited, maybe in the after hours, some healthcare professionals can show up and we can continue this conversation.
So you captured, and I know these first two kinds of microaggressions have just kind of taken a good chunk of the hour in ways that I didn't expect, but I've enjoyed the conversation. But I do want to at least give the audience a taste of this third kind of microaggression, which is really important and falls into one of those categories of things that I can imagine you've gotten probably, if I had to gander, if I were a betting woman, probably more pushback, even as it's incredibly important. And that's the category of self-identity microaggression. And I just want us to really dig into that and give time expressing exactly how that manifests, or one of the ways at least that you take up in the book.
Mm-hmm.
Yeah, good. So we talk about this third category, which Yolanda just described, self-identity microaggressions, which we talk about as causing harm to recipients on the basis of some aspect of their sort of marginalized or non-normative identity or embodiment. So we spend a lot of time talking about fat patients. We also talk about queer and trans patients quite a bit. And so taking that last example, right, if we think about patients with non-normative gender identities or sexual orientations, a common kind of example of a self-identity microaggression that a trans or non-binary patient might experience is being dead named or misgendered in the clinic. And this could happen for all kinds of reasons, right? It could happen because patient records aren't updated with appropriate names or gender markers, because patient intake forms lack any kind of space for a patient to indicate their name, pronouns, ways that they would like gendered language used when it comes to their care, all of these kinds of things. And given the kind of vulnerability around being trans or non-binary in general, being trans or non-binary in a healthcare context that can be incredibly hostile to them, in a social and political context that can be very hostile to them, right? These kinds of seemingly subtle attacks on their identity, on who they are as people, can be really damaging in that context. So we look at a lot of cases of this. A number of patients described it as a kind of erasure, as a kind of feeling invisible, right? Feeling like you aren't seen or represented, right? Because there isn't a place to indicate your name or gender on the intake forms. And then everybody misgenders you, from the person you interact with when you walk in at the front desk to the nurse taking your vitals to the physician. Maybe there's like a compounding of these kind of things. So that's what we mean when we say self-identity microaggression. There are these microaggressions that are targeting some aspect of one's identity or their embodiment.
One,
I feel like you want to say something, Lauren.
I was gonna sort of add one more thing, because this always is really, we haven't really spoken about this. So there's another type of microaggression that happens when there's no agent even there committing a microaggression. So you might be thinking, how can a microaggression happen if nobody's committed it? And I'll tell you how. So, and this we get this from Gerald Sue. So he talks about environmental microaggressions, though he doesn't talk about them in medical context. But one of the cases that we draw on in the self-identity microaggressions chapter of the book is a description, an account that Roxane Gay actually gives in her 2017 memoir called Hunger. The book is sort of an autobiography of her body. And there were only a couple of passages about her experiences in healthcare. But when Heather and I read it, we were like, oh my goodness, these are microaggressions. And one of the ones that she describes is, she's, again, a self-described fat, Black, queer woman. And she is very large. And when she visits a healthcare setting, very often she can't fit on the examination table, or if she can, it's with a lot of difficulty, and she's not clear that it can support her weight. The hospital gown doesn't fit on her body. The blood pressure cuff is too small for her arm. And so those are microaggressions. That environmental context is sending the message to her that you literally cannot fit in our space. You are not welcome here. Even though, like, earlier, Yolanda, you were asking about like blame and responsibility. Well, who do we point a finger at there, right? There's no like individual person who we can say like, okay, who ordered the blood pressure cuffs that are too small, or who ordered the hospital? This is just a systemic thing. This is the size of these things. But what happens when the standard size of these things does not literally fit or accommodate large groups of people? And so this is just another aspect that I think there's much room to be developed of microaggressions that happen when there's no individual committing them, and yet a huge amount of harm is still happening from the environmental factors at play. So that's another part of the self-identity microaggressions.
Yeah, I mean, I thought about the kind of environmental things that happen, and a lot of times, I think the environmental microaggressions are really interesting because these are the things, right? When we talk about microaggressions as often being unintentional or escaping notice of the perpetrators, things that are in our environment are often things that we don't notice until we need them, right? And so
Until they break, yeah.
yeah. Yeah. And so, the environmental microaggressions are incredibly salient in that way, right? Because particularly for people who are on the harm side of that, you see that every day. Like you know that the scale only goes up to 350 and that you may be beyond that. Or that you can't sit in every chair. So I find those really interesting. One thing that I have conversations with my students about is not specifically microaggression, but we think about like universal access or universal designs. And I'll say things like, what does it mean to have a sidewalk if you're a pedestrian and there's no curb cut and you have mobility challenges? And they kind of go, they say the similar kind of thing that gets justified for all kinds of environmental microaggressions. Well, most people don't need that.
Yeah. Yeah.
Well, that's actually not the case. Like, think about even in your own self-interest, right? What if you're pushing something heavy? What if you're pushing a stroller? What if you have a box and you need a dolly? What if, right? There are all these ways in which I think making the world more accessible and more welcoming and just better for all kinds of bodies, I think resolves this microaggression issue, but it also I think it's better for everyone. So, right. So one of the examples that you gave around the self-identity, um, with the non-binary patient who is faced with cervical cancer and is kind of thinking through even the pamphlets in the waiting room, they're all pink and they're all right, right, which is very unsettling for someone who doesn't identify in that way or who doesn't fit those norms. And, as I was reading that part of the book, I was like, there are even cis women who would be deeply resentful of all of the pink crap all over the place.
Oh.
I'm one of them. I've always been kind of a tomboy. And I think, like, who does it hurt to just not have literature, to have literature that's something other than pink? And that's no shade to the people in the room who love pink. But right, I mean, if we're thinking about a kind of welcoming, accommodating space, our bodies do all kinds of things. Wouldn't it be great to just have a range of sizes of hospital gowns? There may be times when, even if your body isn't of size, when we have all kinds of contraptions and whatnot, when we're in the hospital, it may be more comfortable for everyone to just have more room in the gown or to not have to walk down the hall and expose your bits to anybody who's behind you, right? I mean, right. So I think about these as, someone who's kind of interested aesthetically and architecturally in things like universal design. I've been kind of thinking about certainly the kind of environmental and self-identity microaggressions in that way. And I was wondering if you thought about those things.
We have, and we will continue to think about them in after hours. So come join us, everybody.
You can go ahead if you have a quick answer for that. I don't want to cut you off from addressing about Yolanda. That was a nice big piece you gave everybody. A lot of bites on that for sure. Before we're at 7:58, so we just have like 2 minutes before we need to end. So I'm going to be quick here. Obviously, great conversation. Lots of folks, lots of great questions from everyone, being very thoughtful. We appreciate that. All three of these wonderful, wonderful, wonderful philosopher professor types are going to be in after hours beginning at 8:05 p.m. That's going to be about 7 minutes from now. Access to after hours is by buying a copy of Microaggressions in Medicine. You can buy it from our partner bookseller, the Bookstall. There you go, Lauren. Thank you. Buy a copy. You'll get a receipt from the bookstall, and the join link or the registration link for the after hours is right there in that receipt from the bookstall. Yolanda, I want to thank you for a really thoughtful and engaged and really thinking about all the answers. Sometimes we have interviewers who are asking the question, then just looking down at the next question. And I really appreciate your total engagement with the conversation. Heather and Lauren, great to host you. I know that you've touched on many different things that are giving people a lot of good food for thought. I'm going to see if you have one quick question here. Robin is kind of wondering, and I know Robin actually, she's a clinician in psychology. She says, it seems there are so many spaces, medicine, schools, work, even homes, where the response to emotion is to shut it down, almost like people are scared of emotion. Is there a way that the, quote, thicker skin, unquote, responsibility can be held by the witness to the emotion rather than the person expressing emotion? So the witness can toughen up and be a witness, a curious responder, rather than trying to contain and correct people's expression of emotion.
I just quickly want to say, I see that like it looks like Yolanda also wants to say something here, but that, yeah, I love that point. And I think I would add just a layer of whose emotions tend to make people uncomfortable, right? Whose emotional responses in particular, right? It seems like, you might have a cis white person who's really threatened by the emotional responses and ways of emoting of Black women in particular, or whatever it may be, right? So I think I would add the layer of like whose emotions make us particularly uncomfortable and why, and maybe some self-examination around that. And also it's often the case that the people who are making these charges of just toughen up, get thicker skin, quit being a snowflake, are really threatened by these conversations and by the emotional responses that underlie them. So I just think that's a great point that Robin has raised. I don't know if Lauren or Yolanda wanted to add
But you know, we're gonna put a pin in that, and we'll take it up at after hours. So 8 o'clock. Thanks everybody for joining us. Hope to see some of you in 2 nights at our next event, and we'll open up the after hours room in about 5 minutes. So come join us, come hang out. Lots more to discuss. Thanks everybody. Have a great night.